Well, thank you so much for that. You should also not promise for this not being my last until after my talk. So I was asked to talk about gene therapy and targeted therapies in pediatric liver disease, what's in the pipeline. For those of you on the adult side, you can check your phones, but there will be a few things that will be of interest and really be applicable, not just now, but also I think in the future. So just to know, I'm a consultant for these companies. These are non-reimbursed. Here's how I'm going to divide my talk in the next 15 minutes. Some basics about genetic determinants of liver disease. It's not all acquired, and Professor Shagrani and I live this life, that it is really something many of these patients are born with, but you may not also see it till later. I'll talk about medical therapies that are approved. I'll talk about gene therapies that are, in my mind, the most exciting thing I've seen as a physician scientist in the last 25 years just came out this past year, something we've been waiting for. So I'll highlight that and future considerations. But I want to give you a reality check of pediatric therapies in this year. We do have some effective anti-cholestatic therapies. Most of our diseases are cholestatic, so I'll talk a bit about non-cholestatic, but really the focus is cholestatic. Just know that Kasai-Porter enterostomy works, but nearly everybody is cirrhotic, even if it does show flow, and nearly everybody needs a transplant by the time they become adults. Colodocal cysts work, transplants beautiful, but our medical therapies are pretty pathetic. They're not as bad as they used to be, and now there's some excitement, but it's a reality check, just like we were, as Dr. Nureddin said, for MASH, we now have therapies that are beginning to work. But it's a pretty short list. We can use cholic acid for bile acid synthetic defects. We figured out the molecular mechanisms for this, that you can reduce intravenous soy lipids for patients with parental nutrition-associated cholestasis. What's exciting in the field that's real is that IBAT inhibitors work for genetic cholestasis, and I'll really identify this. It's really quite, I would say, remarkable as a physician to be able to really make a big difference in someone's life with these particular medications, but really there's opportunity. Okay, so genetic determinants. On the left-hand side of this slide is where the business end of cholestasis is, which is the canalicular membrane of the hepatocyte. And I'm just showing you representations of the main genes that deliver the products on the right-hand side of this slide, which is what's in bile. So we now know how each of these substances, bile acids, sterols, phospholipids, conjugated bilirubin, go from inside the hepatocyte into bile. And guess what? There's only one transporter for each of these, and they're separate. So if one of these genes or proteins are not functioning at their necessity level, there is no workaround gene to fill the gap. Okay? So it actually makes our lives a bit easier, and we can assign genes to function. The other bit is we now know what we want to treat. So you now have a target here. So I think that this is really quite remarkable. And just to show you the genes and the diseases of interest, it's not my fault. They all have multiple names, just is what it is. But the main one is the bile acid transporter. It's an ABC transporter, ABCB11. And that's what's responsible for all the bile acids on the right-hand side. ABCB4 is responsible for phospholipids. That's the second most prominent. But everyone always follows conjugated bilirubin, but it's a small fraction of bile, okay? But it's really just a color marker of bile flow. So just continue that thought, and that's where ABCC2. So the point I'm making here is that even though we follow conjugated bilirubin levels as our main measure of bile flux, remember that it's really the bile acids which are invisible unless you measure them. So in other words, it's one of the markers, okay? So I'm going to show you some data from a North American panel that we developed and was published a few years ago of what our gene lists are if we try to make a discovery of what's causing cholestasis in children. This is a complex issue. These babies all look pretty much alike in the first few months of life often, and it's very difficult. In the US, we want to differentiate this from biliary atresia, which is our number one reason. That's not necessarily the case here, which is a number 2 or 3 reason here, but it's number one. And what I'm showing you here is about 2,000 subjects. We started a panel with about 60 genes, and then the usual designations of pathogenic down to benign. On the top left here, you see it's really a problem for us in early life, 1st to 3 months of life, okay? So what did we find? Bottom line is this. We're all a collection of variants, and not all of these genes on the 60 gene panel gave us a result. About 32 of them did, and about 12% hit rate. This was all comers. The physician wanted to send the panel, not that there was any real cutoff. So about 12% hit rate. Number 1 was Alagille syndrome. Number 2 was ABCB11. Number 3, because it's a North American population, is alpha-1 antitrypsin deficiency. And then the last one is one that was a surprise. And I bring this up as a reason why we sometimes like to do panels as opposed to individual genes, which we don't do anymore, is POLG, which is a mitochondrial enzymopathy. None of us in the liver world would have thought that this would have been in the top 5. So as a reminder, when you get to see an acute liver failure patient that maybe have had some neurodevelopmental concerns growing up and all of a sudden shows up after a somewhat normal viral illness and liver failure, they may actually have an underlying mitochondrial enzymopathy. Okay. Well, this is work from Dr. Chagranes that I think not everybody in the audience may know, but you should. There's a lot of gene sequencing of families and children with cholestasis. And the genes here are ABCB4, ABCB11. That's why I started this talk by showing you the biology of it. ABCB4 transports phospholipids, ABCB11 transports bile acids. And for those of you who think this is new, the genes were discovered in 1998. So it's really part of our own DNA to know this. I really do expect hepatologists who know HFE, that they're going to know these. So there's a lot more than just these 3 genes that we talk about, and this is from a recent review. And it's nice to separate these into low and high GGT cholestasis. I'll get into the genetics soon, but I'm going to go just to let you know, if you care about this, there's a few reviews on it. And there are several of these that are highlighted that are approved for therapies. So it's good to know what you're treating so you know what drug to use. All right. Last bit before I get to the actual therapies of this is the liver disease is different depending on how the bile acids are retained. And I find this really fascinating. I focus mostly on biliary atresia in my life. And on the left-hand side, you see this massive peribiliary fibrosis. This is the most fibrotic disease in our field. By 6 months of age, these kids have wild degrees of fibrosis. We're learning more about that. The middle panel is from phospholipid deficiency. And that gives you a intrahepatic biliopathy because the cholangiocytes see bile acids without the dampening effects of phospholipids. So you can see this in limited forms with certain degrees of drug-induced liver injury. This is low phospholipid-associated cholestasis, and older patients that have a variety of different biliopathies of unexplained disease. And on the right-hand side is what happens to your hepatocytes when you can't get bile acids out of them, so that the values well up so much. Okay. So I'm going to skip this to make sure I get to the rationale for IBAT inhibitors. So IBAT inhibitor, it's intestinal bile acid transporter. Other name for this gene is ASBT. And we'll call them IBATs because it's easier. And this is in the names of the drugs as well. So IBAT is the way that bile acids go from the distal. I said I can do this, right? So from the distal ileum back to the liver. And if you block uptake, bile acids will then be fecally excreted. So you can take someone whose total body burden is high, especially in cholestasis, when the liver is really welling up, and we've measured this in mouse models, it could be 2 to 3 times normal in cholestatic conditions. IBAT inhibitors drop that down to normal. So what IBAT inhibitors do is that if intrahepatic retention of bile acids is the problem, how do we reduce it? We can't really block synthesis, so how do we block return? All right? And this is one way that we can block return. So this is the therapy that I think allows the liver to heal itself. We do know that livers have this adaptability and there's a mechanism to really handle retained bile acids, but it absolutely gets overwhelmed in these conditions. This is a way to unleash that. All right? So let me show you two trials, one in Alagille syndrome. This is the iconic trial. And what I want to point out for you, this number, 31. This is how many were enrolled in a trial that led to FDA approval. Pretty remarkable, and I'll tell you why they could do it. These were cholestatic, pruritic patients, and if there's something you want to see go away, it's a baby or a young child who's itching and can't stop itching. It's something the sheets are bloody, it's something you want to make go away, which is why we would transplant these patients early, okay? So I want to show you two graphs which look almost superimposable. On the left-hand side is pruritus scores, and on the right-hand side is their serum bile acid levels. And the red bar is a period when everybody was on medicine to start, and in the red bar period is when half of the patients went on placebo and half stayed on drug. So it's a really interesting study design where these patients were all suffering from severe pruritus and said, okay, so if you put everybody on drug at the beginning, you get less itchy, but if for those half in the red that were on the placebo side, their itchiness went back up and then they put them back on drug and it came down. It's a really interesting design. I give full credit to my colleagues in France who designed this. This was really a smart design, and serum bile acids are a corollary to this. Okay, that's on the right. All right, so this led to approval for Alagille syndrome, and I'll show you more. Similar idea in the PFIX. This is the ABCB11 and a bit of the ATP8B1. Similar idea, but this is a standard placebo-controlled trial. This is the other IBAT inhibitor, odevixibat. Same idea, very pruritic, but this is just a slightly different study design. Here, the numbers here were, 62 were enrolled. Same idea, they got less itchy. Those that were on placebo on the right-hand side were put on drug and they got less itchy. This led to approval also. So this is pretty remarkable. So now we have approvals for both diseases, both drugs, various ages, but also if you have older patients and adults who are itchy, this is really something you can think about if you can make a genetic diagnosis, okay? There are concerns with IBAT inhibitors. I heard a bit of that before. The adult colon is a lot less of a good agent than the pediatric colon. You guys get a lot more diarrhea than our patients do on IBAT inhibitors. It's not everybody, but it's a lot more than what we see in pediatrics. So it's just something to pay attention to. All right. Lastly, with IBAT inhibitors, and I'm involved in this trial, and unfortunately there's no sites here at Saudi Arabia, is that there is a phase 3 placebo-controlled trial of odevixibat in biliary atresia, and it's going to read out in June. We'll let you know that. All right. So now I was supposed to talk about gene therapies. Now I'm getting to it, okay? All you need to know is this patient. This patient's name is KJ. This is well known. Born with CPS deficiency. He was born at CHOP. KJ is the baby here. And these two docs here are my heroes on the right-hand side. And so what's interesting about this patient, it is the first patient treated with a personalized CRISPR gene editing therapy, and it was done at CHOP in Philadelphia. First time, this is patient-specific. It's a remarkable story, New England Journal paper this year. And on the right-hand side, I want to point out some of the timeline here, which to me is remarkable. They had a nurse in the NICU who saw this baby was sicker than was necessary. Someone said, get an ammonia, and they got ammonia in the first 6 to 8 hours of life, sky high, and the patient was in the right place, got the right treatment, and dropped the ammonia. CPS1 deficiency is a urea cycle defect, and you just have high ammonia levels. You need to know this early. Unlike my other genes, there's no workaround for this deficiency. They at CHOP were ready to do this. In the first month, they made a patient-specific cell line. They screened. They made a mouse model by month 2. They started to do off-target analyses. They did a primate study. And bottom line is this bit that I hope I can highlight, is they application submitted to the FDA by month 6, first dose at the end of the month. This is an amazing team with amazing working, ready to go. And everything we've been told is supposed to happen with gene therapy, but hasn't to date, and I've heard this for 30 years, is happening. So this is taking not new information from the last few years, Nobel Prize for CRISPR, applying to an individual patient's mutation. And what they're showing, just showing you on the bottom right, is that the ammonia levels are still down after this treatment. They're letting him eat more protein. His other treatments are better. And this is like the best thing. Took his first steps. This is why we're in peds, by the way. This is what you live for, is you see this kid be a normal kid. And so this is what we hope for, okay? There's other viral vectors. I know I'm a little over time, and I'll finish up soon enough. Just to let you know that they use on the bottom level here liquid nanoparticles. And the reason why that's important compared to the viral vectors like adeno-associated is things like this, which you may have seen in the news. AAV vectors are really effective, especially for liver disease, but also for other diseases, and they're being used. Let's say here's one for a muscle-specific Duchenne's muscular dystrophy. But some of these patients have developed liver failure and have died liver deaths after an AAV-directed therapy, and people are working out the mechanisms. But so I'm not saying no to this as AAV, but just this is a point of concern, and so there are workarounds for this. Okay, so future considerations, chaperones and potentiators, and I'll give you a few others, and then we'll end up. We all know cystic fibrosis is a different world now because of drugs that take a missense mutation in the CFTR gene product and let it work well enough at the membrane. Those are these class of drugs. When I was in training, these patients lived to 18. Now and I don't have a picture of it, their actual life expectancy is approaching normal. That's a remarkable story, right? And so the same idea here is if you have a missense mutation of a membrane transporter, why can't we use things like correctors? And here's just an example for an ABCB4 variant that does respond to one of these variants. This is not in any of our common practice, but people are working on this. So I'll let you know, keep your eyes open for that. Other bits is that there are groups working on cell-based therapies. At the moment, I'm not as enthused about cell-based therapies because I think there may be other alternatives as I started the talk, but just to let you know that they're out there, all right? And then the other thing I want you to know that's new, this is the new thing, everybody, is that the kidney is actually more important than we ever thought. That the kidney actually has the same ASBT gene product and reclaims bile acids from filtrate. Okay, so it's really not just an enterohepatic circulation of bile acids, it's an enteronephrohepatic circulation. We would just have a recent review on this and others as well. It's a good one in JHAP, another one in hepatology. I think we all need to know that if we have cholestatic patients for two reasons. One, the kidneys are seeing a lot more bile acids in cholestatic patients, even mildly cholestatic patients, like cirrhotics. These kidneys are changing. The second thing is that even if we affect something like an IBAT inhibition, there's still going to be kidney reclamation. And so in mouse models, if you block the kidney reclamation of bile acids in severely cholestatic mouse models like bile duct ligation, you can fix the liver and the kidney. So I'm just going to let you know that there's something new that even those of us who live in the bile acid world never knew how important it was. And it's really something that I find really quite exciting. So the key takeaways, kidney sees a lot of bile acids. Every heartbeat pumps more bile acids into the glomerular filtration. The proximal tubules see more bile acids, okay? This is a component of kalemic nephropathy. And there's an inappropriate reclamation of bile acids. All right. So in the interest of time, I'm going to just get to the last bit of this slide. There's other cells in the enteronephrohepatic circulation that need to be attended to. The drugs on the top right, I'm sorry I didn't get a chance to mention this before, but norurocolic acid, that's the official name of Norurso. My friend Michael Trauner presented this paper that it actually seems to work in first phase 2 trial in PSC. Pretty remarkable. And so look out for NCA, but also, although Ocaliva seems to be less on the enthusiastic world, but there are other FXR regulators, and as we heard before, the PPARs. So the goal for me is you got to reduce bile acid accumulation, and we figure out exactly how, and genetics matter. All right? So the last bit is that there's hope and progress over time. You all knew who this person was on the left, but I put his name there so you make sure you know who this was. This was Hans Popper. He's the founder of the ASLD. I'm old enough that I was a student at the place where he was, so I got to have a little interaction with him, and we each have a small paper. So I'm really attached to him. But he actually wrote a great paper that I go to periodically because what he said in the 80s is applicable today. And it's a great paper on cholestasis, and what he wrote then was rational therapy of intrahepatic cholestasis remains elusive. I hate to tell you, Dr. Popper, but now we're finally getting there. Took about 70 years, but we're getting there. And gene replacements, base corrections, functional correctors, ligands, and reduced bile acid retention. That's it. Thanks.